So, what is revalidation? Revalidation consists of regular appraisals with an employer based on the good medical practice. It's usually annual, and you can find the good medical practice on the GMC website, which was created, and revalidation was created in December 2012. Doctors must link to a responsible officer, maintain a portfolio showing evidence of following the good medical practice, have recommendation from the responsible officer every 5 years based on appraisals which are sent to the GMC, and based on this the GMC will validate the doctor. So they're usually annual, but the proper revalidation is every 5 years, but they're kind of checked over yearly by the responsible officer. And so this is the progress of the GMC revalidation, which you can look at.
Pre-2000 revalidation. The idea of revalidation came from wanting to ensure doctors were fit to practice and to protect patients from dangerous doctors and ensure good medical practice was being followed. This was because of several medical scandals, and doctors had to submit appraisals, personal development plans, feedback, and CPD records. And this is the CPD cycle.
So what caused this will to change? In January 2000, Harold Shipman, a respected independent GP, was convicted of killing 15 of his patients. Although his opiate addiction was discovered after his completion of medical school, he wasn't stricken off the medical register and was only barred from accessing controlled drugs. However, a funeral parlour and a rival GP became suspicious of the high death rate of patients who didn't have serious conditions, and therefore they reported him, and he was jailed for life and died in 2004. So because they didn't catch Harold Shipman, the GMC was criticised, and also the NHS had failed to audit Shipman's activities such as cremation forms and the high mortality rate and high prescriptions of diamorphine. So in defence, the GMC decided to make an improved revalidation plan.
What is clinical governance? It's a set of principles and behaviours that all doctors are expected to follow to ensure good patient care. And the main points are that doctors should keep up to date, ensuring they adjust practice in response to new guidelines and evidence from research, and then they should audit their responses. Doctors should not place patients at risk and should own up to mistakes if they happen. Doctors should be willing to ask for help when necessary. Doctors should constantly develop their skills and train and educate others, and all staff should be properly supported. Also, doctors should take accounts on feedback they receive. And this is clinical governance.
What's included when clinical governance is? So, yeah, that's everything that's included in basically doctors must follow that. So, the formation of these principles. It was partially due to the Bristol heart scandal, in which 35 babies died and many more were left brain damage as a result of staff shortages, a lack of leadership and lack of organisation of heart surgeries in the hospital. So an inquiry team arrived at the hospital and they saw that the conditions weren't great there. And these are the statistics after they realised what was going on. So the audit.
This is a method for reflecting on, reviewing and improving practice, and they're fundamental for a doctor to take part in to ensure compliance with the guidelines, protocols and best practice standards, and they're important because they identify weaknesses and inefficiencies in the practice. They're used to provide information about quality of care to outside agencies. They provide opportunities for training and education, and there are 3 types of audit: structure of care, process of care, and outcome of care.
And this is the audit cycle that the doctors follow when doing audits of their surgery. So now we're going to move on to the 4 ethical principles. So you can see that there's autonomy, beneficence, justice, and non-maleficence. So let's start with non-maleficence. So this means that the doctor shouldn't harm his patients actively or by omission. justice, so all patients who are in the same position should be treated in the same way, and this includes things like cost of different things. Beneficence means doctors must do good and act in the best interest of the patient. And autonomy is patients are entitled to their own opinion and to make decisions for themselves. They have the right to refuse treatment, but that doesn't mean they can demand particular treatments. So this is a bit more complicated because it depends on patient competence. So if a patient is over 16 years old, they're deemed competent to make decisions of their own treatment unless like proven otherwise. So say like someone is disabled and can't make decisions for themselves. However, if they're under 16, they need to be deemed competent by following the Fraser guidelines. So they must be proven to be mature enough, and they also must be able to understand what's happened to them and what actually needs to take place. So, and this also depends on the type of procedure that the child is undergoing, because it's impossible for children to know what's going on. So we're going to use this example. So this is the case.
So after the Charlie Gard case, there was a baby called Isaiah, and he suffered a severe brain injury during labour, which left him unable to breathe on his own, and he's currently at King's College Hospital. So his parents want assurance that their son won't be taken off the intensive care and switched to palliative care, and they refused permission for doctors to end his life, and they disagreed that to do so would be in his best interest. And his mother said that it's felt like they've been trying to pressure us to accept that Isaiah should die, and it's up to us to look after him for the rest of his life. And they're telling his parents that he should die. The King's spokeswoman said that our patient sadly had a serious and profound brain injury and has been cared for in our neonatal intensive care unit since his birth 5 months ago. Sadly, despite intensive treatment, he remains fully dependent on life support. We've been and continue to work closely with the family in discussions about the long-term prognosis and plan of care, and it would not be appropriate to make any further comment.
These are the ethical decisions. So in autonomy, Isaiah is under the age of 16, and therefore he's unable to give consent for himself, and therefore is in the decision of the patient. So in this case, the patients have decided to keep him alive, and so the doctors should listen to them. But we have to consider other things as well. So beneficence. So what is the best thing for Isaiah in this case? So they believe that the best thing is palliative care, as he has been in the neonatal intensive care unit for 5 months, and he might not have enjoyed being there for so long. And if this is how his life is going to run, like, is it the best thing for him really? Non-maleficence would be like, so not harming him. So if you take the baby off life support, it would cause death, which is basically what doctors want to avoid. And justice. So National Institute for Health and Care Excellence recommends treatment at a cost of £30,000 per quality adjusted life year or less. So it might be more expensive to fund Isaiah, and therefore it's not fair, and like not all the patients are being treated the same. So all of these have to be considered when making an ethical decision, and this is something in interviews when they give you an ethical problem, using this way to answer the question could be the best way really.